Is prehab effective prior to ACL surgery? What's going on, guys? My name is Dan Pope. We also have Kevin Coughlin. We are physical therapists. As always, we're combing through the medical literature on big topics, and we're taking all the important information, throwing out the garbage, giving you our clinical experience, and bringing it to you today. How's it going today, Kevin?
Dan, it's going well. I'm excited for this one. I think it's, initially when we were talking about what topics to do for the ACL for podcasts, I thought this would be a good bias check because I obviously think prehab is good for a lot of things. So I'll talk about kind of what the research says here, but it was fun to go through.
Nice, man. I'm also pumped. This is one of the things I believe in as well. So we'll see what the literature review showed.
Yes. All right. So yeah, what does the evidence say? I'm going to talk about a couple different studies. This first one was a systematic review it included 3 randomized controlled trials. So it was from 2020 and it was titled The Effectiveness of Pre-Op Rehab Programs on Post-Op Outcomes Following ACL Reconstruction. So we're talking about reconstructions and looking at a couple of these randomized controlled trials. So awesome. So just a little bit of background. So this systematic review included 3 studies that were randomized controlled trials that the authors concluded had a high risk of bias. So just in the study design, that's kind of what they were finding. All studies included variations of strengthening, neuromuscular control drills, balance, and perturbation training. So there was a little bit of variation within the study, but they all included something along those lines. And the frequency of the PT prior to surgery varied from 10 to 24 sessions, and that was spread over the span of 3 to 6 weeks. And their findings were that there were statistically significant differences at 3 months after ACL surgery for improvements in quad strength and single leg hop scores in the prehab versus the control groups. So they did find that there was some benefit, and specifically in the quad strength and the single leg hop. There were no statistically significant difference between groups for pain and for self-reported function, and that was at 3 months post-op. So in this kind of study here, with this systematic review, they did find some benefit to prehab, which I thought was awesome.
Dang, dude, freaking hop testing 3 months post ACL reconstruction.
I know, isn't that crazy?
Hardcore, dude.
Yep. No, I don't know if there were any re-tears. They didn't say, but that would be a bummer. So this is from the author's conclusion. They concluded that there's very low quality evidence suggesting that prehab offers a small benefit for improvements in quad strength and single leg hop scores 3 months after ACL reconstruction compared to no prehab. There's no consensus on the optimum prehab program content, frequency, or length of time. So, I wanted to start out this episode by talking about, I think, the highest quality study we have, at least in terms of including randomized controlled trials. I think surprisingly to me, there weren't a lot of studies with randomized controlled trials for this particular topic, but there are a lot of cohort studies. So kind of prospective and then retrospective studies that I'll talk about coming up. But this was a good one to start off with, I think.
Hey there. Sorry to interrupt, but I've got something cool. It's an evidence-based exercise selection cheat sheet after ACL reconstruction. Sometimes it's a little bit scary working with patients after ACL reconstruction. Obviously, you don't want to hurt them, and the exercises that we choose matter. So I created a cheat sheet to help you out. It goes over which movements have the most strain on the ACL graft and how to dose those exercises from low to high. We use the evidence to guide us so you can make the right decision for your patient after ACL reconstruction. We'll also tackle that age-old question of whether or not you should be using open kinetic chain knee extensions with your patients early on after ACL reconstruction. This cheat sheet is 100% free. I'll leave a link in the show notes in the description below. Go ahead and click on that and get to learning. Now, back to your video.
So kind of diving into the next study that I thought was a really, really good study. This was published in BJSM in 2014. And this is with a research group that you kind of see come up time and again in the ACL world. And the study title was, "How does a combined pre-op and post-op rehab program influence the outcome of ACL reconstruction 2 years after surgery?" a comparison between patients in the Delaware Oslo ACL cohort and the Norwegian knee ligament registry. So they're comparing these two different groups and how do they do with a structured pre-op and post-op program compared to kind of your standard of care. So can talk a little bit about that on the next slide. A little background on the study, just about the Delaware Oslo group. So this is the University of Delaware has been conducting a lot of really good, high quality research on ACL, ACL surgeries, ACL pre-op, ACL post-op, and they work in conjunction with this hospital and team in Norway, in Oslo, I guess. So you'll see that in the research, that group that is working together. And if you're looking at the slide, the left side of the screen kind of talks about what patients are in the Norwegian cohort of the Oslo study. And then on the right side is how they're comparing groups. But they're comparing knee function pre-op and 2 years post ACL reconstruction in patients undergoing progressive pre-op and post-op rehab versus what they're deeming as usual care. So they compared the outcomes of two groups. The first group is what I'll call the NAR group, and that's the Norwegian Research Center for Active Rehab. That is the University of Delaware's cohort in this study. That's the control group. And they're comparing that to the experimental group, which is the Norwegian Knee Ligament Registry group. And this is where any patient in Norway undergoing ACL surgery gives their information. They kind of take all the information about the patient, what type of graft they're having, how long after surgery they're getting, how long after their injury they're getting surgery, if they're doing prehab or not. All that information goes into this registry. So they're looking at this control group versus the registry of patients. The NAR group, so the control group, underwent at least 5 weeks of pre-op PT before ACL reconstruction. And I thought what was nice about the study here is that they created some criteria that they were shooting for before letting these patients go into surgery. So what they were asking is they were trying to get at least greater than or equal to 90% muscle strength. And that's in terms of quad strength and hamstring strength, and hopping ability on the injured leg compared to the uninjured leg prior to surgery. This group of researchers previously showed a significant short-term improvement in knee function and a low rate of adverse events with this approach. So that's a study that I will talk about in a little bit. They used their protocol from this previous study. And the outcome of interest at 2 time points is what they were looking at. So preoperatively was time point 1, and then 2 years post-op was the second one. And what they were using as their outcome of interest was the KOOS, so the knee injury and osteoarthritis outcome score. The inclusion criteria to be in that Delaware group, the control group, the NAR group, was a unilateral ACL rupture in the last 3 months. So we're looking at more acute injuries. The age range for their study, their cohort, was 13 to 60 years old. And they had to be participating at least 2 times a week or more in a pivoting sport. So these are people who are at least doing some high level of activity. They're not sedentary folks. The exclusion criteria was that they had a bilateral knee injury. They had MRI, which showed other grade 3 ligament injuries. So they were allowed to have some, irritation or damage to the ligament, but not a grade 3 ligament injury. So a full tear. They were excluded if they had a fracture or they had articular cartilage injuries. Meniscus injuries were only excluded if they had symptoms during the prehab program. And that was during the plyometrics. And a couple people did, which I'll talk about. And their symptoms did not resolve at 3 months from the injury. And then, so that was for the control group, the general inclusion criteria and exclusion criteria to be part of the study. But what they looked at for comparison with the Norwegian Knee Ligament Registry, the NKLR group, was that both groups, they wanted the patients to be between the ages of 16 and 40. They had a primary ACL reconstruction. And then the exclusion was similar things. So they didn't want to include anyone that had a concomitant cartilage surgery or surgery to any other knee ligament, which included a PCL or LCL or an injury to the posterior lateral corner. They couldn't be included if they had a previous cruciate ligament injury to the contralateral knee or previous surgery to the knee, the index knee, the knee that they were doing in this study. So I thought that was good. They tried to group together similar patients. That's obviously a big issue when we have a lot of diversity. Some patients have all these other concomitant injuries. Some patients are 16 years old and some patients are 60. So they did try to group them together a little bit into similar characteristics, which obviously makes our study more reliable. So I think pretty good job there by the authors. Okay, so getting into the study, what did they actually do? What did the PREHAB group look like? So they did a 5-week preoperative rehab program, which I'll talk a little bit more about in a future slide. And that goal for them was to their aim was of achieving greater than or equal to 90% muscle strength, as well as quality performance on hop testing. And I thought this was interesting because I think myself and other therapists I've talked to, we get a little bit nervous before surgery of doing anything to further damage the ligament or something else in the knee. But I think with their program, what we were seeing is that, they were saying it's okay to do some plyometric training pre-op. It's okay to do some aggressive strengthening. We obviously want to monitor pain and swelling, but if we can get patients to this, and this is what we'll talk about, why prehab is important, they definitely show that patients who hit this criteria before surgery do better after surgery. So their rehab program consisted of heavy resistance training, plyometric training, and neuromuscular exercises. Again, I'll talk a little bit more about that study coming up. And they initiated it as soon as joint effusion and range of motion deficits were resolved. So that's something important to keep in mind, is they weren't having these folks do plyometric training with a bunch of swelling and limited range of motion. They were thinking of this in a phased approach. So, let's phase 1, get down your pain and let's get down your swelling and improve your range of motion. And then when that stuff's resolved, perhaps not going right into surgery, let's try to get these other metrics hit, greater than 90% strength compared to the other side, decent performance on the hop tests, and then initiate surgery. So their findings were that there were large differences in the KOOS sports and the quality of life subscales favoring the NAR cohort. So that group that did the prehab. Compared to usual care, they had superior pre-op patient-reported knee function, and they still exhibited superior function 2 years after surgery, with 86 to 94% of patients scoring within the normative range in the different KOOS subscales. So a big win for prehab in this particular study when they're comparing it to the usual care in Norway, at least. But I think that's probably pretty good proxy for usual care everywhere.
Yeah, that sounds awesome. I love to hear it. That's pretty cool. One of the things I will say, and just like the length of time, basically from the injury to surgery, and the ability to do plyometrics and more aggressive strength training, I've had this happen with some patients where they're like, do I need surgery? Right? It's like they're hopping, right? They're lifting heavy. They're doing a lot of stuff that's sometimes more than what they normally do. And the thought process becomes, crap, now I'm going to get surgery. I have to do this all over again. So, yeah, really good to see that this prehab is helpful, but also frustrating for patients because they get to the point where they're feeling pretty good, range of motion resolved, quads coming back, strength is getting back there. They're hopping, they're jumping, and maybe even more than what they're used to doing in the past. And then now we're going to go back and get a surgery and start all over again. Mm-hmm. But good to see that it helps, right? Definitely good to see that it helps.
Yeah. So just a summary statement from the authors of this particular paper is they said, it is likely that the patient education, the psychological strategies utilized by the doctors and the physical therapists treating the NAR group differ from usual care. So, they're saying that it's probable that these patients were getting better care than our standard of care or what we usually see. So that's a consideration. And they believe that these patients benefited from more comprehensive follow-ups in a clearer goal setting than usual care. So they were really good about hitting their kind of preoperative goals. And I think, whether it's showing that this exact protocol is the best or they're kind of saying that it's the attention to detail, perhaps, that you get when you do this type of pre-op strategy versus the usual care. There's probably so many factors of why these patients do better. But they wanted to just make note of that it might not be the exact protocol, but it's kind of everything put together that you don't get when you go a traditional route where you maybe don't do prehab and you just do your surgery and, that kind of thing. I think what's really good about this group of researchers is it's almost like as they design their research studies, they have a long-term plan in mind. So this study that I'm about to talk about came before the study I just talked about. This is where they designed their prehab program. And then they said, okay, now we have a good prehab program. Let's put that into the study I was just talking about and see how these folks do with our combined prehab and post-op program. But this is their initial study that they did in 2010 that's titled "A Progressive 5-Week Exercise Therapy Program Leads to Significant Improvement in Knee Function Early After ACL Ligament Injury." And this is where they were trying to validate their 5-week pre-op program and see how it does before surgery and post-operatively. So we'll get into the details a little bit more here. So a little bit of background. This is a prospective cohort study. So there were 100 patients which were included in a 5-week progressive exercise program, and that had to start within 3 months after the initial injury. Knee function was evaluated using isokinetic testing. So they were testing both the quadriceps and the hamstrings, as well as the 4 different single leg hop tests that you see in a return to sport type setting. And then they used 2 different self-assessment questionnaires and a global rating of knee function scale. So they had a lot of kind of good data in here together to conduct this study. And their findings were that a progressive 5-week exercise therapy program led to significant improvements in knee function from pre to post test. The observed improvements in muscle strength and single leg performance were moderate to strong, indicating the observed improvements to be clinically relevant. So this is how they validated their pre-op program, and they found that doing pre-op physical therapy, which included strengthening, neuromuscular training, perturbation training, balance training, plyometric training, led to better outcomes in kind of all the markers that we would care about. So it's pretty good. And further continuing with this study, they noted the rationale for the study draws on previous data. So the 5-week progressive program includes strength, plyometrics, general exercises for balance and stability, and perturbation training. So what they use to justify adding these things, why these things? So for quad strengthening, they were looking at other studies that showed that individuals with pre-op quad strength deficits above 20%, so less than 80% symmetry before surgery, they had persistent, significantly larger deficits 2 years after surgery. So, a lot goes into that. Is it just because they couldn't hit these numbers pre-op? Probably not. But, maybe that means a more significant injury. Maybe that means that they're not at a place where they're getting good quality rehab, but it's a good marker and something that we want to shoot for preoperatively. So we know if your quad's very, very weak before surgery, we can see deficits up to 2 years after surgery, which is pretty crazy. Now, when I think of this type of prehab, I'm definitely thinking of strength. But one thing I was reading that I thought was interesting, and I mentioned to Dan this week, was Lynn Snyder-Mackler, one of the researchers here from Delaware, conducted a study focused on perturbation training. And what they did, she had a whole protocol, and that study's referenced in the references page that you could go look at for the specific protocol in their progressions. I thought it'd be too much to add to the episode, but it's worth looking at. They had a perturbation training and strength training group versus just strength training alone. And the study showed that a combination of perturbation and strength training pre-op led to more symmetrical gait at 6 months post-op, as measured by knee excursions compared to just strength training alone. So doing that preoperatively seems to be more helpful for normalizing gait post-op at 6 months, which I think is pretty wild. And what they talk about when they're looking at knee excursions is that when you think about like your jumping and landing mechanics, or they're looking at gait specifically, but healthier knees tend to have a little bit more movement and play. It's that person who's not doing so well that when they're walking, their knee is so stiff, they're not getting that terminal knee extension in part of the gait cycle. And it looks like they keep, 15 degrees of knee flexion throughout the entire gait cycle. And those are perhaps folks who, if they did some perturbation training pre-op, could have a little bit better gait quality later down the road. So I think that's an important thing to think about. And, I don't want to do a disservice to her protocol and every single progression they had, but very generally, it's kind of like they're on a rocker board and they're doing kind of different, double leg, tilting forward and backward, tilting side to side, progressing to single leg. And, it's when they're on a surface that's unstable. So unstable surface training is really what they were doing. And they were progressing throughout from double leg to single leg, and then increasing distraction. So kind of doing things with their upper extremities, and just they were progressively making it harder. And that's the type of exercise that they were incorporating with that.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms, or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. Yeah, good stuff. I was just the perturbations, so they just kind of like manually giving perturbations as they're moving, perturbing the rocker board, that kind of thing.
So in this study, I think in her protocol, it was more the rocker board was providing the perturbations for them. But you could easily get creative with that. And I know kind of one of the godfathers of physical therapy, Kevin Wilk, he's always posting content like this. And I know he's very creative with his perturbation training. So you could always check out some of the stuff he's putting up there. But I think that type of thing, you can make the challenge almost infinitely hard by perturbating the person or perturbating the board that they're on. But just starting, I think for her protocol, it was mostly going from double leg to single leg to different, anterior to posterior is a little easier, I guess, than medial to lateral. So kind of starting that way and then progressing. But I think we could definitely make it harder too by, working on hitting the person and that type of thing.
All right, makes sense.
Yep. And then just their justification for adding these other things is there are some studies that show for plyometric training, it enhances muscular strength and athletic performance. That's well studied just for performance in general, not just for rehab. But one thing that they did note is that because they did include patients with meniscus tears in the study, some of those patients with plyometric training specifically had a flare up in their knee. So 3.9% of people in the 5-week program had an adverse reaction, and the adverse reaction was with plyometrics. So these patients were just getting more swelling, and they had criteria for, are you able to continue doing this or not? And for them, it was, if you're having an increase in swelling that doesn't return back to baseline within 24 hours, we have to go down a level in your pre-op program. So for these folks, they found that these particular people, when they went in surgically, the surgeons were seeing evidence of a meniscus tear. And the authors, they did note in the study, they didn't think the tear was from the plyometric training. They didn't think the mechanism was substantial enough to create a meniscus tear. But I think that's something to keep in mind. I think for me, if there's one group of training that I'm probably going to be cautious with pre-op, it would be plyometric training. But I also think that what they showed here is with the vast majority of these 100 patients, only 3.9% of them had an adverse reaction. So most of them didn't. And we can be confident and feel safe doing some plyometric training before surgery. It's probably a good thing to do. And then their justification for neuromuscular exercises was that exercises for proprioception and balance may improve dynamic knee stability and thus functional ability in patients. And they kind of grabbed that from a study on neuromuscular training. So they were searching for justification for using these things in their pre-op program. And I think it was pretty valid stuff.
Yeah, that's cool. Seems like one of the takeaways is that you work pretty hard with these patients pre-op. One of my thoughts is, and I posted this stat recently, I forget the author, but something like only 30% of folks after ACL reconstruction, so after they get surgery, even do plyometrics, right? And they're advocating for plyometrics prior to surgery. The majority of folks don't do pre-op. So it seems like you're doing a very robust job. It's not like you're returning back to sport prior to surgery, right? You're not doing that level of degree of skills, plyometrics, running, so on and so forth, but you're getting pretty dang close. And it sounds like you probably want to be nice and robust with your training. Because my takeaway is, generally speaking, in the past, I haven't done any plyometric training with my pre-op ACLs, but I think I'm going to start doing it now, Kevin.
Me too. I mean, that's definitely something I'm guilty of, is get nervous, and even like heavy strengthening. I think I've been more apt to do blood flow restriction training. But I do think, like you had said, there are a lot of patients in this cohort that the week before surgery, they're like, wow, I feel so good. Like, do I even need the surgery? And that's probably the point you want to get them to, because we know how quickly much muscle atrophy occurs, and how quickly, not even just muscle atrophy and strength, but probably the fast twitch muscle fibers, and like how quickly people move, that kind of agility and speed. People lose that so quickly that if you're able to hold on to that as long as possible before surgery, I think that's good. And I was surprised that I think we tend to see in our area, doctors are good about wanting people to wait a little bit for surgery. They definitely want to achieve that quiet knee. And I think it shows that if they're doing at least 5 weeks of pre-op in this study, we don't have to rush surgery necessarily. Let's take our time and make sure that we're in a good spot before, because it can really lead to better outcomes after. And, I think this study was pretty good at showing that.
Yeah. I know that, if we rush this process and get into surgery too fast, that may lead to problems as well, right? And I think the other part is that, basically, from our last show, we talked a little bit about how delaying doesn't necessarily cause problems as long as you're not doing anything crazy, right? You can delay even for years, up to 2 years. I think the one study we're talking about, and not have any adverse event from a meniscal standpoint, anything along those lines. So I think the main thing is that it's going to be a planning issue. So you're going to have some patients who want to get back to sport. So when you get the surgery, kind of dictates how long it takes afterwards. Obviously, there comes a planning issue depending on when your athlete wants to get back. But if your individual athlete doesn't have a schedule, right, and they can get back whenever they want to and have a longer runway, maybe we just do a better job early on, and that can lead to better outcomes, right? And it's not like you save time per se. If you do 6 weeks of rehab at the start, doesn't mean you can return back at 6 months, right? You still have to wait until 9 months, whatever it is. But at that 9 month, you'll probably be better off if you do the work beforehand. That's what it seems to be.
All right, so just putting it all together here, it does seem like kind of a summary slide that prehab prior to ACL has been shown to improve preoperative strength, hop testing, and function in cohort studies. There are only a few randomized controlled trials that I found. There might be more out there which have replicated these findings, but in the studies we have bias is high and more studies are definitely needed. This is always challenging though, because if you do feel like pre-op is really helpful, it's hard to create a study where you're not giving your patient that, right? You kind of know you're doing harm in some sense. So you wonder if that's why there's not a lot of studies looking at that. But maybe we'll see more over time. I don't know. And then the best available evidence we have right now suggests that first, most important thing is that we restore range of motion and abolish swelling. So they talk about getting swelling to a 1 on the scale that we tend to use for swelling. So that would be where you can kind of milk and sweep away a little bit of the swelling, and then it doesn't come back on its own unless you push it there. If someone just has constant pouch swelling in the knee that you can't get rid of, you probably want to get that down a little bit before surgery. Progressively loading everything, but especially the quad and the hamstring in open and closed chain is safe and something we should do before surgery. We should include some perturbation training and neuromuscular training in a progressive fashion. And I think there are some pretty good protocols out there. One of them is the Lynn Snyder-Mackler study that is in the show notes. And then include plyometric training if it is well tolerated and safe to do so. And just be sure to monitor pain and swelling. And if you are having an increase in swelling, take a step back in the rehab program and go to where you knew you were having success. You don't have to hammer plyometric training. I think if they're not tolerating it well, that's okay. Don't do that. But if it's safe to do so and they're doing okay with it, don't be afraid to add it. I think that's kind of a good takeaway here. So hope that helps and you start doing a little bit better rehab here, or prehab, I should say.
Prehab for sure. Kevin, I don't know if you came across this at all, but in terms of strength, so basically 80% LSI is what we're looking for prior to surgery.
Yeah, I think their goal was close to 90. They didn't exclude people from surgery if they didn't get that. They didn't say you got to keep training, but that was their goal. And I do think at least 80% is definitely some criteria they were advocating for.
Okay, yeah, that makes sense. So, and it does, and this has kind of scared me a little bit too, but safe to handheld dynamometry test these guys as well, right?
Definitely.
Kind of freaked out, and especially when I remember a patient when I was in my first or second year, something like that. It was my very first pre-op ACL, and I was like, "Holy God!" Like, initially, it's real swollen, very painful. This was just a particularly painful patient, right? Like you definitely see those folks a tear. And you're like, "Did you really have a tear?" Right? But this patient was very sore, very scared, very fearful, and I was just faking it. I was like, "It's okay, you'll be all right." And I just exercised with her, and I just trust like some of the research, but it was freaky. I'm like, "Am I going to cause a cartilage injury? Meniscus injury? Is your joint stable at all? Can I do these things?" And I think the answer is yes. Obviously, be smart in the early stages. You're trying to get the swelling down, trying to get range of motion back. Don't do jumping or aggressive strengthening when they're still very swollen. Like you said, you're trying to achieve that quiet knee first, but we definitely want to get that quad back on board. To me, my rehab is very similar to early post-op ACL reconstruction. So I'm using things like NMES. I'm using things like blood flow restriction training. We're using ice. We're doing a lot of frequent range of motion throughout the course of the day. We're being gentle at the start. And then as they progress, you don't have to be fearful. Like we can do squats, lunges, single-legged deadlifts. We can do some hop training. Just treat it like you would, let's say, patellofemoral pain or non-op meniscus tear, something along those lines. It's a pretty similar rehab, but just we know that we're eventually going to go get surgery if the person decides, or maybe if they're happy enough, they won't. Who knows, right?
Yep. Yeah, and one thing I'll say there is what I've been tending to do recently for the pre-op patients is, maybe their first time in physical therapy during the eval, if the injury wasn't that long ago and they're still really painful, is get strength numbers for the non-operative side first. And then, I always will do a manual muscle test in the position that I'm going to do the dynamometer testing and see if it's painful. Like if day one, they're swollen and it feels terrible, you don't have to test that day. If the surgery date is not for a month or so, test before the surgery and let the knee calm down. Do a lot of the exercises you were just talking about, get them in that test where I'll manual muscle test again. And then they're like, hey, this doesn't hurt. It feels fine. Then I'll take them and strength test them with the dynamometer. So, you can be a little strategic about it. You don't have to test them day one if their knee's really painful. They might be afraid that you don't know what you're doing because why are you having them push through this pain? So just be smart about that. And you want to get those numbers if you can, but don't go crazy at the expense of making the patient hurt and not trust you. You could test later. You can always test a little bit later before surgery.
Yeah, it makes total sense. And the other thing that we're constantly battling, this is, alluding towards the next episode, but when we're trying to rehab folks after ACL reconstruction, the problem is that the surgical side is getting stronger, but then the non-op side is getting stronger and stronger and stronger and stronger, even faster sometimes. And we know this. There's studies that show that the uninvolved side is getting stronger, and it's getting stronger than it was prior to surgery, right? So if you can have a fresh ACL tear and test that contralateral side, you actually get a more true baseline, because as you progress them through strength training, if you're doing a really good job with your strength conditioning and that patient is not used to strength conditioning, they're going to get much, much stronger on that contralateral leg too. It ends up being a little bit frustrating. It's a problem we'll talk about how to solve probably in the next episode. But if you get that test number prior to them getting the ACL reconstruction, especially if it's close to the initial injury, the contralateral side, that's actually a decent measure of where they kind of ultimately need to be, or obviously where they started beforehand. So, all right. So you did a great job with your pre-op program. Your patient's ready for ACL surgery. But what is the best type of ACL surgery? What's the most important graft? Do they do repair? What about this new bear thing I'm hearing about? Well, Kevin, we have the video for you. And I'm going to leave that link above Kevin's head. I want you to go ahead and click on that. We go over the best surgery for your patients after an ACL tear. Click on that and I'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.